Rush will finally be inducted into the Hall of Fame, which is good. Yes. Who says countertenors from Canada can't get in the Hall of Fame? There's a lot happening at Boulder Community Hospital with stroke. And stroke is always the most common reason neurologists are called to the hospital. But that's not changed. What has changed is we're now a certified stroke center. And I'll talk a little bit about what that means. First of all, just in general, when you're doing an evaluation for stroke, there are key points you want to focus on. This is what we do when someone comes in. It's getting what happened at the moment, if possible, of the event. Sometimes we don't know. Sometimes the person's by themselves and they're simply found. But ideally, we want to know the onset. We want to know how things have changed over time. Has there been any loss of consciousness at any point during the event? Any convulsions, any chest pain? Why do we care about chest pain? Because we want to know maybe this person presenting with a heart attack at the same time as a stroke. Anything is possible. And the more information you get, the better. The more likely you are to be correct in your diagnosis. We want to know if the person's had prior intracerebral hemorrhages. This will have implications on whether we can administer TPA, the clot lysing medicine. Have they had a recent stroke? Have they had head trauma recently? And again, have they had any recent cardiac events, specifically myocardial infarction? We want to know about surgical procedures if those have occurred, and the general view of how they've been, if they've been ill recently or exposed to someone who's been ill, and also their medications. In the simplest sense, we're just reviewing the key points the neurologist is going to focus on. In the neck, we want to know what's happening with their carotid arteries, listening to see if we hear a bruit or a clue that there might be a blockage there. The cardiac exam, again, you might pick up atrial fibrillation, you may pick up valve change, something that gives you some insight as to why a stroke may have occurred. And then the big focus becomes our neurologic exam. And now, as part of our protocol, we'll be adding an NIH stroke scale to everyone who gets admitted. We want an onset, we want 24 hours, we'd like a discharge NIH stroke scale. Not that this changes how you manage somebody, but it's documentation. It'll help us in our reviews of patient and acuity and figuring out how well are we doing with the sickest patients, and are we providing adequate care for people who have severe or minor strokes. The NIH stroke scale, if you don't know, is about a 30-point stroke scale where low numbers are good, high numbers are bad. A variety of imaging studies are available, and they include CT, CT perfusion, CT angiogram, MRIs, MRAs, carotid ultrasounds, and echocardiograms where it can be transthoracic or transesophageal. We take advantage of all these modalities at the hospital. This is imaging of CT using perfusion technique. In the top left, slide A, when you perfuse a vessel, that area of green, all this area here, is the at-risk tissue. So imagine the left middle cerebral artery being occluded, and this much territory is at risk if nothing is done to help. On the CT, you really don't see anything. There's not much evidence, as is usually the case for acute CTs, that you find any evidence of stroke. The next bottom left, slide C, this is the size of the infarct ultimately, which is smaller than this area. And the difference between these two is called a mismatch. Here's the amount of tissue that actually died, this is the amount of tissue that's at risk. And if you intervene, the hope is to make this area smaller. And I'll show you some other slides that talk about this and illustrate why does that matter. This is an example of what MRI technology provides for us. A similar case, in this case the right middle cerebral artery territory, you can see quite easily the bright white light telling you there is a giant stroke here. CT scan is not likely to show that. Certainly the first 6 hours, and mostly at least 24 hours before you'll see that kind of resolution. This series of pictures shows an initial presentation in the top left here. This is diffusion-weighted imaging, so what is bright white is consistent with tissue suffering ischemia. And the equivalent here on a CT There are differences, but they're much easier to see on an MRI. What is the difference? Well, here you see the sulcal markings, the dark, and those folds. On this side, you don't see those folds. There's early edema development. You can tell, and this is what we did all the time when we were making rounds 20 years ago, but now MRIs are even better. We don't typically use MRIs acutely because we want quicker information for a CT. But MRIs definitely give you much better prediction of where the infarct is. And then the next below there shows what happened. This is a person who received TPA, and that large area on presentation went to this. This is a follow-up a week later. You really don't see much here. This is a T2 weighted MRI. In this, you're seeing this diffusion-perfusion mismatch. You'll start hearing that term more, and it's to show what happens when you compare the area of tissue that actually appears to be suffering from stroke and the area that's at risk for having stroke. So the way to think of it is, you first see the MRI with diffusion-weighted imaging. This bright white is the area of ischemia, a little bit here near the cortex. But this is the perfusion area. All that territory is at risk. And ultimately, this is what you would see. That area at risk turns out to be the ultimate size of the infarct, which didn't look so bad here. This looks terrible. So our goal is to be able to recognize that some patients may have a large difference in risk tissue. And just because their initial diffusion scan doesn't show a lot of tissue damage doesn't mean they aren't at high risk. It justifies being aggressive as possible. There have been some attempts to try to justify longer windows with use of TPA and other interventions outside of the 3 to 4.5 hour window. That's still being worked out, but it will keep advancing. We'll get better ways to predict. Part of what we're hoping is that we'll eventually be able to figure out the individual who awakens from sleep in a reliable fashion when their deficit probably occurred or when is the safe window. Because we lose a lot of cases where the person was asleep and awoke with a deficit. We have no idea when it started, therefore we can't give them TPA. These are some examples of imaging technologies that can show different vascular anomalies. Specifically, this one on the far left showing a basilar artery narrowing here. This is showing a dissection of the right or left internal carotid artery. This is a very characteristic appearance, a tapering of the lumen down to this small little point. What's happened is a flap in the wall has been dissected out and created this phenomenon radiographically. There's supposed to be a lot of blood vessel here. There's hardly any. Here's the little tiny lumen of the internal carotid artery, proximal internal carotid artery stenosis, and another example here. All the dark you see there, that little wedge, that will be a plaque that's blocking the flow. So all of this can be imaged through our various modalities and give us a lot of insight. At this point, when people come into the emergency room, the standard protocol is to get the CT scan and get the CT angiogram unless there's a distinct contraindication. You lose a maximum of about 5 minutes. CT angiograms are incredibly fast and efficient. We know at that moment whether we're dealing with severe stenosis of a large vessel or not. And we can also see whether smaller vessels are blocked. And it helps in our planning for what we're going to do in the first hour or two in the emergency room. There's the possibility of getting it wrong, and it happens occasionally. And there are mimickers that are important to know about when you're looking for, well, what else could look like a stroke. Individuals who had an unwitnessed seizure could wind up with left or right-sided weakness, a so-called Todd's paralysis. It's temporary, but if they're caught and perhaps the individual may not be able to communicate effectively, you might assume there's a stroke. So you want to consider that, find out the history of seizure. There have been patients, including one of mine, that came to the emergency room that somebody you know who's recently been wearing a halo because of his neck fracture. He has repeated seizures, and he came in and I was called as an acute stroke alert because no one knew him when he first came in. I said, oh, I know this man. He has seizures all the time, and sure enough, within about 15 minutes, he was back to himself again, and his hemiparesis had resolved. So when you know the details about someone's history, it makes a big difference. Hypoglycemia can present as a stroke. Someone can have a severe low blood sugar. And this is standard to check, of course, but if it were to be forgotten, you might make a mistake. The most common thing we'll see with students is aphasic speech, numbness on one side, scares the heck out of them, just like it would scare any of us. They come to the ER, and the good news is we get to tell them you're having the equivalent of a stroke, but it's called a complex migraine R. That can happen. So any young person who presents with acute neurologic problems really should first be thinking, is this a migraine? Yes, it could still be a stroke, but much more commonly these individuals are coming in with a temporary deficit, and it's where you can often give a lot of reassurance that you're not having a stroke, and that's what we're going to try to avoid. Hypertensive encephalopathies, it'll come with the presentation. Someone who is particularly hypertensive can wind up having neurologic deficits. Reactivation of old deficits, that's not uncommon. An individual in a nursing home might be developing pneumonia, have a bladder infection. The old left-sided weakness may get a little bit worse. In those cases, often we're not in a position where we'll say, well, let's treat aggressively because this is what they've had, it's just a little bit worse. It's probably not a new stroke, it just may be worsening old deficits. The mass lesions we won't miss because we're looking for them with imaging. Subarachnoid hemorrhages, usually we don't get called, it's pretty much the ER and then neurosurgery. But there could be cases where someone might present with subarachnoid hemorrhage and you can miss it if you aren't looking carefully at certain aspects of the CT. A real tricky one that we all hate to miss is the older individual who presents with vestibular dysfunction, vertigo. Someone who has vertigo, usually it is inner ear, just a vestibular problem, but sometimes it turns out to be ischemia. And as we're getting CT angiograms, sometimes we're able to pick up a basilar or vertebral artery stenosis, the areas that feed that part of the brain. That can give us insight, or even diffusion studies. We could get a diffusion study within about 30 minutes and be able to see if that portion of the medulla, for example, has ischemia. We've seen those cases where they present just with isolated vestibular dysfunction. And finally, the toughest of all is when someone has psychiatric history, is presenting with a conversion problem. Usually there are enough signs and clues on the exam that something doesn't hold together, but it can be tricky. And I've had cases where we've felt stuck, we weren't sure, and we've treated it as if it were a stroke because the consequences are too great if you miss it. So how do you treat stroke? There used to be a big joke, I remember my wife's medical school class when they graduated, did the thing on stage, and they called acute stroke alert on stage, and then all the residents rolled a giant aspirin tablet out on stage, and that was the glory of neurology. We got to give someone an aspirin. Now at least we get a little more credit for doing something interesting, and that's giving TPA. And TPA has been around for a while. 1996 was FDA approved. You have a window, initially of 3 hours. That was the package insert. There's been support now for 4.5 hours unless the person is over 80, has an NIH stroke scale of greater than 25, or has had a prior stroke and diabetes. Those are reasons you still wouldn't do it. We do have a little lengthening of that window of time. Keep in mind, though, it's critical to get the TPA as soon as possible. Every minute matters on the statistics, and it matters a lot. But only 2 to 8% of people get TPA who have stroke. Still a tiny number. Many reasons it doesn't happen, but that's still a problem. How good is TPA? Because there's still dissent about whether we're really doing anybody a favor by giving them TPA. We're exposing them to the 6.6% risk of an intracerebral hemorrhage, and how much better off are they going to be? Important to know that there's no data that people who get TPA get better in the first few hours as a result of your TPA. They might, but that might have happened anyway. The statistics said these people do better at 3 months, to this tune of 39% in the treated group had minimal or no disability compared to 26% in the placebo group. It does matter. It's good that there's a difference, but it isn't dramatic. It's still a good therapy. It should be considered standard of care, but we still want it to be better. And better means sooner. The sooner you get it in, the better these statistics are going to be. There was, I put in that last line that just the other day there was an article, a good study looking at, well, what about people who don't have any evidence of a clot on a CT angiogram? And it appeared there was not that much difference, if any, when you gave TPA or not. So that clot itself being gone, logically you would say, well, maybe TPA is not going to do much for someone whose clot isn't even there. So it makes sense that in those cases we may miss that. Well, doesn't mean we shouldn't give it, not yet, but there may be some changes over time as to who specifically should or shouldn't get TPA. What about other options? We had a case 2 weeks ago, and a 66-year-old man came in with his left side weak. He was just sitting at work and acutely started to slump a little bit. He was there, he got TPA intravenously within about an hour, and then we sent him to the interventional suite, and he had intraarterial TPA administered, trying to get this large MCA clot dissolved, as well as some mechanical disruption attempted. That part didn't work, but we had the ability to give him a case that was at, when he came in the door, at 50% mortality. When you have a complete occlusion of your proximal MCA, we were able to at least try to get the clot out. And I'll give you feedback at the end of where he stands now. The devices that can be used, there's the Mercy device that was made famous years ago on an episode of ER when someone took out the clot. The Mercy device is a device that has a little coil in it. You deploy it when you go through the clot inside the vessel. And this corkscrew grabs the whole of the clot and you literally pull it out. Then a newer device is Penumbra. And that device works a little bit better. There's a catheter that will move through the clot, break it up, and you have a suction that's created, and the clot can come out through a suction process. It's the preferred catheter at this point, according to our interventionalists. And Penumbra is precisely what that man had when he was in the interventional suite. Again, it was too big a clot burden, they couldn't get it out. It doesn't always work, but it's an amazing thing to watch, someone actually getting a catheter into the middle cerebral artery and trying to get the clot out of there. I just put that in because it's kind of cool, that picture of that. You have technology now where sound waves can disrupt clot, and there's already evidence that if you send sound waves through clots at the same time you're giving TPA, you may break up clots better. So look for that in the future. It probably will become another way to treat and disrupt clots. You're just breaking up those molecules just enough to get the TPA substance in there to help break up the individual clot material. The stroke center designation came a few months ago for us. It's a comprehensive process that involves lots and lots of paperwork, documentation on protocols, having protocols in place, and this has been studied as to whether it matters. And it does matter, just the way it matters if you follow guidelines in neurosurgery. It doesn't dictate how you care for every individual patient, but if you have in place a system that says, do this, followed by this, and we all are on the same page, you can avoid those variations that might lead to delays. And for the most part, you're getting patients out of the hospital faster when you do this, which is definitely the name of the game. Get them out of the hospital, get them to rehab, get them home, and you can save costs by doing this. So this has been a welcome change the hospital we've been pushing for years, and it finally happened, so we're happy about that. So I'm going to present a few different types of stroke presentations, and just to give you some insights about how does this individual present, what can you see, what kind of data do you get. This is one I've presented this before several years ago. It's just still an interesting case, a 37-year-old who had a headache and neck pain as his chief complaint. He had a history of cervical spine disease, neck pain for several years. He was returning on a plane. He got some increasing pain in his left shoulder, feeling tightness. He'd had some chiropractic care with some improvement in his neck pain before. A week later, he was having intercourse and developed acute neck pain, headache and orgasm. Symptoms persisted despite Vicodin. Brain MRI was obtained, which was negative at the time. And then he noticed his pupils were unequal and saw the left one wasn't dilating. And that is a sign of what's called Horner syndrome. he had Warner syndrome, the small pupil fails to dilate in the dark. It's consistent with a sympathetic interruption. The sympathetic fibers run along the carotid artery, so when you see that, it's possible something's happened in his carotid artery. It turned out he had a left carotid bruit on his exam, and he was someone I saw in the office, and he gave me the story, and then we went from the office to the hospital and got a CT angiogram, and it showed this. Here's a normal internal carotid artery, here's one with a lot missing. And he has this phenomenon here. There's a angular flap that's created from his dissection. This is called a pseudoaneurysm, because it's not the traditional aneurysm at a branch point. It's created by the defect of the tear in the wall. Fortunately, pseudoaneurysms usually don't have to have anything done about them. They usually don't rupture as if they're extracranial. If they're intracranial, there's concern. But you can also do things to try to block it off for protection, maybe help the healing. This can be stented. In his case, he ultimately didn't have a stent. This is a case about 6 years old. I think now we'd probably refer him for stenting, but you don't have to. You can still, despite as scary as that looks, these patients' natural history is good recovery, and he ultimately has never had any recurrent problems. You have to think about carotid dissections in cases of trauma, but it can occur spontaneously. It's a commonly forgotten differential in cases that present. You may find it on the radiographic studies, but when someone's had trauma, it's definitely a consideration. And we've had patients who have asymptomatic dissections. That's not rare either. These patients are candidates for TPA. That's been a common question. You don't make dissections worse. You decrease the risk of stroke, because what's happened is blood is dissected into the wall, and they've got a thrombus there that can break off and create a stroke. And we may do angioplasty in these cases. All right, so a person presenting with acute right-sided weakness and aphasia. That presentation is almost always left hemisphere, or dominant hemisphere for language in 95% of us. And you're usually going to find the person has a fairly substantial sized stroke, typically in the middle cerebral artery territory. This is an initial CT. You really can't see anything that's distinct. But this was the evolution over time. That area of the left middle cerebral artery territory where you have edema. So that's the classic presentation of the MCA stroke, aphasia, and right hemiparesis. Someone has acute left-sided weakness and left-sided neglect, and we're thinking about a right middle cerebral artery territory stroke. The neglect comes typically from cortical involvement, a neglect phenomena most of you probably encountered, but it's very intriguing, interesting to see individuals who will either say, I have nothing wrong with me, even if their left arm is paralyzed, or aren't aware of how profound their deficit is. Everyone who works with these people knows that they're typically extremely difficult to rehab because there's often the lack of awareness. And the person is supposed to get up and walk. You know, well, you can't move your left side. I'm fine. And so they try to step and then collapse. So you can see lots of problems. You're always trying to get them aware of what actually is wrong. It's a peculiar phenomenon. If it's deeper, not at the cortical level, you usually don't get the neglect part. So right hemisphere isn't always a neglect syndrome. When it's right hemisphere cortical level, or a lot of the just subcortical region, you may not find the neglect part. So again, this is an initial scan of a person with that presentation and a diffusion-weighted imaging showing what's actually there, a large area of ischemia in the right middle cerebral artery territory. Same presentation of someone having the aphasia and some right-sided weakness and numbness, just a difference in the appearance of the scan. This is diffusion-weighted imaging MRI, showing areas of acute ischemia. Just for reference point on MRI, how long does it take for diffusion imaging to show positive and how long does it last? It's usually going to show up within an hour or two. You're quickly going to see changes on MRI. So if we can ever get MRI fast enough to not delay treatments, it will supplant CT for that purpose. But we're not there yet. But it's a really nice test. So you see these multiple areas rather than one confluent or single vascular distribution. It's all MCA, but multiple little spots. So when we see something like that, and this is a little bit higher up, it is possible that there's a narrowing and little emboli occurring off of a thrombus in the vessel, but it also raises the possibility of a more distant site embolizing like a heart. You can always consider multiple emboli from a cardiac source or atheroma in the aorta might present this way. This helps guide where you're looking and what you want to emphasize. It used to be thought we'd see something like this and we'd say, oh, they're embolizing from somewhere. We need to put them on heparin. And the answer is, unless they have a known clot, you can see the heart in their atrial fib or valve disease, heparin isn't the standard of care. And there have been studies to show putting these people on heparin just when you see a pattern like this is probably detrimental because you're increasing the risk of bleeding unnecessarily in someone who didn't actually need the heparin. What about someone who comes in, gets TPA, we got them in the window, we're excited, and they suddenly start getting different after that? Unfortunately, there can be the bad outcome where that 6% occurs in somebody, and that stroke that was significant turns into a massive hemorrhage. Now, the neurosurgeons are put in a terribly difficult position most of the time for this, and most of the time, it's not a surgical treatment. There might be cases, and we've had some, where particularly the younger individual, we've gone ahead and suggested, yes, it's worth it because they're so devastated. Let's see if that burden of clot can be taken out. But it's a tough problem. You try to reverse the anticoagulants. You can give all of the counteracting measures through the vein and even try to remove it. But most of the time, these individuals are either going to die as a result of this or have a very bad outcome. But fortunately, it's still relatively rare. So as dramatic as it is, and it does tend to influence your experience, if you have a patient who has this occur, it makes you a little more skittish, but it's not a reason not to give TPA, and that's why we tell people it's about 6 to 7% risk that this could occur. The final part on that patient I mentioned earlier who had the large stroke in his right middle cerebral artery, we gave intravenous TPA, tried intraarterial, tried to mechanically disrupt the clot. That couldn't be done, but he went to the ICU. We called neurosurgery early on, which is also our new protocol. Let them know a person has had a large stroke, their help might be needed. And he got the expected swelling to develop and started to have mass effect and shifting from right to left, and ultimately went to the OR. Dr. Beasley did a craniectomy on the right side, removed the skull so that the brain would have somewhere to swell. And he got through that extremely well. He had some hemorrhage into the area of the stroke, but despite that, his deficits were not worse. He remained able to communicate with us, and 2 days ago, he's gone to rehab. So he's on the way to recovery, even though he's got a massive stroke. Almost for sure, without taking off the skull on that side, he would have had a herniation syndrome and died. So it's nice to know we have the ability to protect even the greatest strokes, the largest, biggest strokes. And it's becoming the way to go. Most of the literature now is saying if you see that this individual is going to have massive swelling, don't wait too long. In a controlled environment, go ahead and remove the skull on that side and allow that brain to have somewhere to swell, because it can be life-saving. We've seen that in other cases over the years. Fortunately, they're fairly rare, but I think it'll become more common because we know that's a way to save these people's lives. All right, any questions about stroke care, anything that's changed at our hospital, or any issues in general about stroke you would like to ask?
Yes, do you routinely hospitalize somebody presenting with acute TIA?
It's not turned on.